Today we'll continue our lectures about hereditary diseases affecting the kidney, and we'll talk about an important one, which is Fabry disease. This is our agenda. Disease is a lysosomal storage disease, X-linked, due to deficiency of an important enzyme called alpha-galactosidase A. Very important, don't forget the name of the enzyme, alpha-galactosidase A, and this deficiency will lead to accumulation of glycosphingolipids in the cells. The sphingolipids are important component of the cell membrane and membrane of the intracellular organelles. So we have a deficiency of alpha-galactosidase A that will lead to intracellular accumulation of glycosphingolipids. The most commonly affected organs by this accumulation are the kidney causing CKD and end stage, nerves causing pain crisis and acroparesthesia, autonomic dysfunctions that will lead to sweating abnormality, the skin that will lead to angiokeratoma, heart that will cause ischemia, and eye abnormalities mainly in the form of corneal opacity. So it is a multisystemic disease. What about the etiology and pathogenesis? As we said, this disease is X-linked disease, so males are more commonly affected and with a more severe presentation due to this X-linked inheritance. As we said, the deficiency in the alpha-galactosidase A enzyme, and there are more than 500 mutations in the GLE, which is a gene for this deficient enzyme. As we said, glycosphingolipids will be accumulated, and glycosphingolipids are normal component of the plasma membrane and membrane of the intracellular organelles. The glycosphingolipids that accumulate in Fabry disease are identical to those found in normal tissues. What about the clinical manifestations? As we said, Fabry disease is a multi-systemic disorder that usually affects the kidney, heart, nervous system, either peripheral and central nervous system. As we said, this disorder is X-linked disorder with severe manifestations in males, and heterozygous females have a variable disease course and usually less severe presentation and less severe course. In affected males, the initial features begin in childhood and early adolescence, mainly by the nervous system affection in the form of paresthesia and pain in the hand and feet. These are usually the first presentations, are paresthesia and pain in hands and feet with episodic pain crisis. CKD usually leads to end-stage renal disease in between the third and sixth decades, and myocardial and cerebral infarctions are usually terminal events. We will focus now on each organ that can be affected in Fabry disease, and we'll start, of course, by the kidney. The earliest affection of the kidney is mainly a concentrating defect, and usually followed by proteinuria, hematuria, and progressive renal impairment that usually lead to end-stage renal disease between third or fourth and fifth decade, between 30s and 60s. Nephrotic syndrome is unusual, and usually we see, due to the accumulation of the glycosphingolipids in the epithelial cells of the kidney, Usually we found urinary oval fat bodies. Don't forget that. Urinary oval fat bodies with a maltase cross configuration when viewed by polarizing microscopy. As we said, due to the large amount of glycosphingolipids in urine, this is a very important feature or finding, urinary oval fat bodies. So we have urinary oval fat bodies, proteinuria, hematuria, and progressive renal impairment. What we found in renal biopsy? In renal biopsy in Fabry disease patients, in light microscopy, as we said, the main pathogenesis here is the accumulation of the glycosphingolipids, and they are usually seen in the visceral epithelial cells of the glomeruli. The glomerular visceral epithelial cells are enlarged and packed with vacuoles, small clear vacuoles. Don't forget that. Small clear vacuoles are usually deposited in the kidney. The main site for this deposition or this accumulation are the glomerular visceral epithelial cells. By vacuoles, these vacuoles, clear vacuoles, can be seen in the parietal epithelial cells and in the distal convoluted tubule and loop of Henle, and the epithelial cells of the distal convoluted tubule and loop of Henle, and they can be shedded in urine and can be seen. These epithelial cells of the distal convoluted tubule filled with these glycosphingolipids material can be seen in urine. They are rarely found in mesangial cells and endothelial cells or in the proximal tubular epithelial cells. These vacuoles are also observed in arterioles and arteries in the endothelial cells and smooth muscle cells of the arterioles and arteries. So the main affection or the main finding in the light microscopy is vacuoles or vacuolation in the glomerular visceral epithelial cells and parietal epithelial cells and epithelial cells of the distal convoluted tubule and loop of Henle. And this is a very important picture of this light microscopy. As we see here in the H&E stain, we found in the glomeruli these clear vacuoles. These clear vacuoles due to the deposition of the glycosphingolipids, and here as we see with oil red or stain, these vacuoles due to glycosphingolipid accumulation. What about the electron microscopy? The main finding here is inclusions. In light microscopy, we said vacuolation. In electron microscopy, we found inclusions within the lysosomes. As we said, it is a lysosomal storage disease. Inclusions within the lysosomes, particularly of the visceral epithelial cells. As we said, they are the main site of accumulation, visceral epithelial cells. These inclusions can be accumulated in a concentric pattern, concentric layers, or arranged in parallel. If these inclusions are arranged in a concentric layers, they are called myelin figures. Don't forget that myelin figures. If they are arranged in parallel arrays, they are called zebra bodies. So these inclusions, if arranged in concentric layers, myelin figures, or arranged in parallel appearance, so they are called zebra bodies. Also, we can find detachment of the visceral epithelial cells from the underlying basement membrane. As we see here, this is a characteristic and a pathognomonic pattern of Fabry disease. As we said here, this is the myelin figures arrangement in concentric layers of the inclusions, and here are the zebra bodies in parallel arrangement of the inclusions. Very common to be present in different exams, master or MD. We finished the kidney. Now we'll talk about the heart. The main pathogenesis again is the glycosphingolipid accumulation, usually in the coronary artery endothelial cells and in the myocardium. In coronary artery endothelial cells, this will lead to coronary artery narrowing, which will give a presentation of angina, myocardial infarction due to ischemia, and congestive heart failure. Also, a very common finding is due to deposition in the myocardium is left ventricular hypertrophy. Also, arrhythmias are described in Fabry disease patients due to infiltration of the conducting system. So in the form of ischemia and heart failure and left ventricular hypertrophy. What about the nervous system, which, as we said, is a prominent feature, and usually a very early presentation of Fabry disease patient is the autonomic dysfunction in the form of sweating abnormalities in the form of hypohidrosis, and the most important one is acral paresthesia. Paresthesia, tingling, numbness in the extremities, in the hands and feet with pain. This is usually the first presentation and a very, very common presentation of Fabry disease, acral paresthesia and pain. Also, altered intestinal motility have been described. Also, glycosphingolipid accumulation in the blood vessels reaching the brain will lead to narrowing and ischemia of the cerebrovascular circulation that will lead to manifestations in the form of hemiparesis, vertigo, diplopia, dysarthria, nystagmus, nausea, vomiting, headache. Also, vertebral basilar circulations is involved, and intracerebral hemorrhage and infarctions are usual, can be present usually in patients with Fabry disease. Dementia have been also described in some patients. So don't forget acral paresthesia and pain. Now we'll talk about the skin affection, which is very common and important in Fabry disease. And the characteristic skin affection in Fabry disease or abnormality is called angiokeratoma. Angiokeratoma is a very characteristic. It usually occurs early in the course of the disease. In the second decade of life, it can be the earliest presentation. It usually presents as dark red macules or papules. Typical locations include lower trunk, buttocks, hips, genitalia, and the upper thigh, and usually in the swimsuit region. In the lower trunk, up to lower down up to the upper thigh. So specifically in the swimsuit distribution. On histological examination, this angiokeratoma consists of dilated small veins covered by hyperkeratotic epidermis. So it's an angio, dilated small veins covered by hyperkeratotic epidermis, so it's called angiokeratoma. And telangiectasias can be known especially behind the ears. This, don't forget, there's a very important picture about the angiokeratoma around the umbilicus, periumbilical. As we said, dark red macules or papules in the area around the umbilicus or periumbilical region. What about an eye? The characteristic eye abnormality in Fabry disease or corneal opacity. Corneal opacities can occur in about 75% of patients. It's called, also termed verticillata, corneal opacity called verticillata, and are identified by slit lamp examination as whitish discoloration that radiate from the center of the cornea. Also, cataract can be observed in Fabry disease patients. Now we'll talk about the diagnosis. The diagnosis in affected males, as we said, is usually can be made clinically. Found a patient with angiokeratoma, corneal opacities, and painful acroparesthesia. They are the classic presentation of Fabry patients, Fabry disease. So very high suspicion. Also, we can found corneal opacities by slit lamp examination to confirm our diagnosis, and this diagnosis can be confirmed by assessing the alpha galactosidase A activity. Alpha galactosidase, the enzyme activity, the deficient enzyme, will found decreased or absent activity of this deficient enzyme. Usually it's less than 15%. Can be tested in serum, leukocytes, and cultured skin fibroblasts. So mainly clinical and deficient enzyme. If the enzyme levels are equivocal, now we will focus on the slit lamp and measurement of the urinary ceramide molecules of the deficient pathway that will be accumulated in those patients in the form of urinary ceramide digalactosidase, galactoside, and trihexosides. And of course, we can do genetic testing. What about the treatment? Very simple. We will give the enzyme, the deficient enzyme, will replace it. So in the form of enzyme replacement therapy with recombinant alpha galactosidase A enzyme. We'll give the alpha galactosidase A enzyme. And this replacement by this enzyme usually leads to reduce the plasma and urine GB3, which is one of the glycosphingolipids, and leads to amelioration of the neuropathic pain, enhanced quality of life, and the deposition from the kidney, heart, and skin decreased or even cleared after replacement by the enzyme, and with improvement of the cerebral blood flow. Also, it leads to stabilization of renal function in patients with mild or moderate renal impairment. But the impact of this enzyme replacement on long-term renal outcomes is still unclear. We can give our patients RAS blockade with the enzyme. In patients with end-stage renal disease, we usually continue to give the enzyme to decrease the extra-renal manifestations or to improve the extra-renal manifestations of the disease. Can be infused during hemodialysis, but the main problem is that this enzyme is very expensive, and usually it is needed to be infused for a long term. What about renal transplantation in such patients? Renal transplantation is effective treatment for advanced Fabry nephropathy, but it doesn't, of course, ameliorate the extra renal manifestations. Fabry heterozygotes shouldn't become kidney donors, of course, and recipients with Fabry disease should or are candidates for enzyme replacement. Usually gives them enzyme replacement to improve the extrarenal manifestations. To summarize, Fabry disease is a lysosomal storage disease It is X-linked disease due to deficiency of the alpha-galactosidase A enzyme. This will lead to accumulation of glycosphingolipids in multiple organs. The main clinical manifestations of Fabry disease include angiokeratoma, Meswin's lesions, neurological affection mainly in the form of painful acroparesthesia, especially affecting the hands and feet with pain, eye manifestations in the form of corneal opasitis, and kidney that will lead to CKD and end stage renal disease. Renal biopsy in light microscope, don't forget the vacuolation or vacuoles, especially in the visceral epithelial cells of the glomeruli. Also, we will found lipid-laden tubular epithelial cells. As we said, tubular epithelial cells are infiltrated by these glycosphingolipids and can be shedded and found in urine. Electron microscopy, don't forget inclusions in the lysosomes. Inclusions, they are arranged in concentric patterns, so they are called myelin figures, or in parallel pattern, so they are called zebra bodies. The diagnosis is mainly clinical by the clinical manifestations of, and we can ask for slit lamp examination to find or to search for the corneal opacities. We can found lipid-laden epithelial cells in urine, and of course we can check the enzyme activity and we will find reduced alpha-galactosidase A activity, and we will found elevated serum GL3, which is one of the glycosphingolipids. Of course, the treatment is by giving enzyme replacement that will lead to slowing disease progression. Our sources, and thank you.